The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello and good day to our viewers, our listeners, for the next episode of TMD Demystified. I am Tony Urbanic. Today, this morning, when I'm recording this, it is a little harder to keep a smile on my face if it ever is easy to smile. Today, we're going to talk about an elephant in the room that has come to my attention. I am not certain how I am going to title this episode. I'm not sure whether it is going to be very brief or whether it's going to go on for 30 minutes. If that's a warning to you, but I think that you will find it interesting, truly. So let's get started, and at the end of it, I'll figure out what we're going to call this when we get it published. So it came to my attention recently, as if you are a dental provider, you may have already been aware of it. There has been a controversy and an investigation about an intraoral fixed device called AGGA, A-G-G-A, which is called the Anterior Growth Guidance Device, which is promoted by a dentist in Memphis, Tennessee. Not to be confused with a dentist, oral surgeon, physician in Nashville, Tennessee. But we're going to talk about this and what it really means to the profession. I'm not really concerned really about what it means to us and the Urbanic device. I can defend ourselves extremely well. Actually, what I have already in place and documented on almost 2 years of episodes and information on this Dental Town podcast will clarify, and I have clarified in multiple areas and multiple episodes, the kind of activity that has been going on in dentistry that is exemplified by what has just come to light through an investigation by CBS News and Kaiser Health News, who have partnered together, and now it's all over the media universe about a device which has been shown to be extremely destructive and invented or promoted by a doctor in Memphis, Tennessee. He is not the only one. I could go down a laundry list, and I'm going to, as I have before, without trying to call any person out individually. I don't see the need to do that, but to call out what has been going on in our profession for a long time, going all the way back to, as I mentioned multiple times, when I was a dental student and was faced or exposed, probably better word, exposed to the concept of using a night guard to treat TMJ problems, as it was called then: headache, earache, jaw pain. I was in dental school and I was exposed to this, and I remember vividly, I went, well, I can see you're covering the surfaces of the teeth, but how does that stop somebody from grinding their teeth? How does that help the pain? It didn't make any sense to me. And actually, at one clinic, I asked that question, and I was given word salad back. I don't remember every word, but I remember thinking that explanation, whatever it was, didn't explain it to me. I mean, and then what are you going to do then? You've asked your professor to explain it to you. He gives you some word salad that doesn't make any sense. And then what are you going to do? Ask him again? That is a fact. Now, as you all know, I have been involved in treating temporomandibular joint problems for the entire span of my career, starting in my training at Vanderbilt, where we learned to do temporomandibular joint surgery. David Hall, my professor and mentor at Vanderbilt, actually has published articles about condylotomies, which is doing vertical subcondylar osteotomies to bring the condyle out of the fossa, which actually has some validity to it, except it has potential complications, significant potential complications. And that particular procedure I never did. I never felt it was going to be successful because of the potential complications, which I had seen when you actually distract surgically the condyle out of the fossa. It does take the load off the temporomandibular joint. It does allow the inflammation to go away, but it also sets you up for a potential to have significant occlusal problems. We could have a whole episode on that whole thing and explain it to you in my experience with it, but that isn't the point. It has now come to, I think, a significant head. I think this problem that I have discussed now for 2 years, and that is TMD, whether it be surgical or non-surgical, it is in the hands of the profession and individuals in the profession who go down dirt roads and rabbit holes that don't lead anywhere and have the potential to actually do quite a bit of significant harm. Now, of course, when a provider does anything, there is potential for harm. That is why you go to school. That is why you have a degree. That is why you have a license. And your training is designed more to actually keep you out of trouble and keep you from doing things that are harmful than actually doing the things that are helpful. It's like flying an airplane. You spend 10% of your time flying learn how to fly an airplane and everything that goes with that. And 90% of your training is spent on how to handle emergencies or keep yourself out of trouble flying an airplane. So, flying in airplanes is a dangerous proposition, as is the practice of medicine or dentistry, because you have a patient's body in your hands to do things that can cause problems, whether it be medical, surgical, physical, chiropractic, physical treatment, physical therapy. So, but when it comes, as it has come out over the decades, which I have experienced since actually entering dental school in 1969, exiting dental school with a dental degree and a master's degree in cell biology and anatomy in 1973, it began there. And of course, when I trained at Vanderbilt, we began doing surgical procedures for the temporomandibular joint in an era where the whole surgical philosophy was unnoticed, unknown, untrained. We're stumbling around, honestly, and we were honestly trying to be honest. But it has come now to a point where, because of the internet and because of the access to investigators, and I'm sure that this has not gone unnoticed by the legal establishment who makes their living chasing problems and suing people, that this AGA controversy is going to expand. And it's going to expand for sure, because almost immediately it became my attention that the FDA is now intimately involved. I turned around because on my computer on the other side of my chair, my desk here, there's a notice from the FDA, evaluation of safety concerns with certain dental devices used on adults, called the FDA safety communication. I'm not going to read the whole thing to you, but now the FDA is involved, and I promise you now that the FDA is involved and the legal teams who sue people are involved, and the investigators, as witnessed by CBS and Kaiser Health Network and Kaiser Health News, have brought this to our attention, rightfully so, because this particular device, I was not aware of it until a month ago. And I really didn't even investigate it, or once I even made aware of it, it just kind of went over my head, and I went, wow, that sounds terrible. But for the past 2 weeks, I've actually did my own investigation of what's going on, because it became very obvious that this had come into the mainstream. So, and it's just an example. This AGA device is now joined with many other devices, but according to the FDA, including, let's see if I can list them out here, some of these other, an AGA device, a FAGA device, an ARA device, a FARA device, an AURA device, and a FORA device. I'm not even sure what all those things are. But those apparently are fixed devices, but also this is going to expand, I'm certain, into removable devices. And actually, I am aware of a removable device that is designed and promoted, which will go unnamed at this time, but a removable device that is designed only to do the same things that the fixed device is designed to do, and promoted in a way that when you put enough pressure, literally orthodontic pressure, on the teeth to expand the oral cavity both laterally and anteriorly to treat sleep apnea, but also stated, which made no sense to me, how that was going to also treat TMD. But it made no sense, but I had the description both verbally and in textbooks and how that was supposed to actually treat TMD, which exemplifies as simplicity I don't know what else to call it, nonsense, and describe word salad. Because if you know the basics of facial growth, how bone is laid down, which I think every dentist should know, but I can tell you they don't. That is not covered in dental school. I have a specific episode on dental education in TMD. We're on this is episode number 95 now. And we're coming up, we're going to have a little celebration, hopefully when we hit 100, which will be in just a little over a month. But I bring this textbook to your attention. This textbook is the seminal textbook on facial growth, the quintessential seminal textbook, the iconic textbook on facial growth, by Dr. Enloe, Donald Enloe. This is my original copy that I have now read twice when I was a young doctor and doing my PhD evaluation and research and fellowship with the NIH, had my own research project. That's another story that I will mention maybe some other time. But I did I was granted my own research project in facial growth and development, and part of what I did, not expected to do, wasn't asked to do, but I read this textbook word for word, page for page, actually twice. It's the best thing I ever did, because Dr. Enloe is the authority on how bone is laid down in and around the face, oral cavity, and skeleton, and the facial skeleton. And if you understand what he writes here, it's obvious that pushing on teeth are not going to cause bone to be laid down. Now, that does not include, obviously, for obvious reason, we're not talking about palatal expanders in children. 2 points about children. Teeth move through adolescent or mixed dentition bone extremely fast, like a hot knife through butter sometimes. But palatal expansion is possible because the palatal raphe has not closed at that time. And so if you're careful enough and you go slow enough, you can get palatal expansion in a child. This is typical dental information. Hopefully you all know this. But to expand that concept into adults is foolish. And that is, now I mentioned one device, the AGA device, and another device, which is a removable device, that state that you can lay down bone by expanding against the teeth. And that has obviously come to the forefront. It will come to the forefront. And because of the FDA's involvement now, I can tell you that any and all oral device is going to be sooner or later involved in this. And because we see, literally hundreds and hundreds of patients a year, 20 consults a week for TMD alone, I have to say I have some knowledge. Do I want to call myself an expert? No, I do not. I don't ever want to call myself an expert, frankly. I don't need that moniker. Experienced, I'll take that one. That's what I started out saying since 1969 in dental school, 73 in finishing it, and then as a oral and maxillofacial surgeon intern, resident, working, following that with the NIH for 2 years, academically completing a PhD in cell biology and anatomy. I do have some experience, and then treating TMD surgically for 30 years and non-surgically for 12. So Dr. Donald Enloe, he clearly states how the facial growth bone, and my work in facial growth and development on my research topic with the NIH, NIDCR had everything to do with facial growth and development. So it does not look favorable for my colleagues in the dental profession. If you read these 2 or 3 episodes on CBS that are now on YouTube, have like hundreds and hundreds of comments, which I've only read, a few, 15 or so, but they are not favorable for our profession. And I have always respected my professions, both dental and medicine and medical. I respect my colleagues because I was in the trenches together with them. I knew how we learned. I knew how most of us felt about our professions. But this is a big kick in the no pun intended, kick in the teeth regarding what's going on and has been going on, and which I've been, quote, preaching about now for almost 2 years, about the things that are being done for specifically now TMD. I don't need to go off onto sleep apnea, but these 2 devices I mentioned have been promoted for not only sleep apnea, but for TMD, which makes no sense at all. All right, just a couple examples further. I'm not going to, like I said, I don't know how long I'm going to do this, present this diatribe. I hope it doesn't come across as a diatribe. I'm trying to help here. I'm trying to get to the point of view where I can get understanding with my colleagues, because honestly, I have something significant to say. We figured it out. The symptoms actually arise, the symptoms are generated by inflammation within the temporomandibular joint. That's where they're generated with the inflammation. Now, the inflammation is caused by chronic bruxism, acute trauma, and functional malocclusion. And that's what creates the inflammation. But the generation of the symptoms is from inflammation. So if you can make the inflammation go away, you can make the symptoms go away. It is that simple. So I'm not going to beat that drum for the 94th time. It's all over these episodes, but I'm going to beat the drum a little bit for what are we going to do now that we have this problem? And it's all about understanding. That's why I've taken the time once a week to spend 30 minutes with my colleagues and go through some of this stuff to make it obvious. All right, so I mentioned I mentioned the night guard. It's still taking place. Literally 50% of the dentists in the country will make a night guard, give it to the patient who has one or more of the TMD symptoms and says, here you go. Here you go. Here's your treatment. And of course, I have patients coming in, I call them brown baggers. They'll come in with a little brown bag and they'll shake the brown bag as they come in the door, or when they're sitting there, they want to show me the contents of the brown bag. Of course, I already know what's in the brown bag. 2 or 3 or more. One lady, I think she probably had at least 10 of them in the bag that wanted to show me. They were all one rendition or another of a night guard or something like it. So let's kind of quickly dispel the concept that wearing a night guard is going to decrease bruxism, because we don't even know the mechanism for bruxism, let alone how to decrease it. The only thing we know about bruxism is related to stress. We know that. We are certain of that, but we don't know a whole lot more. There are a lot of theories. I'm not against theories, but they're theories of how stress actually converts into bruxism neurologically. Botox. I've talked about that before. That is also on the agenda here. For you dentists who are using Botox and think it's clever to treat muscle spasm or muscle tightness, you need to know that Botox for TMJ is not approved by the FDA. It is, you are using it off-label and therefore taking a significant risk. It is not approved by the FDA, and it is approved by the FDA. Botox is a good service. I think it's a great service. You want to decrease some of these or whatever, make the lines go away in your forehead. I think Botox is awesome, but not for TMD. It's used off-label. And of course, it's not effective. I mean, you know, for that pain, if this is always hurting right there, you can put Botox in there and you'll paralyze that muscle and it'll never tighten up. It'll never pull on the bone. It'll never create the pain until it wears off, at which point you will get the patient back in your office, maybe for another Botox injection, which is what all my colleagues, I have actually heard it. I mentioned it in other episodes. I was in the room with 20 or 30 of my other colleagues here in Tennessee and given the Botox lecture, and the presenter said, and the best part about Botox is the patient will be back in 4 to 6 months for another set of injections. That's the best part. And everybody kind of giggled, and they giggled. Everybody knew what she was talking about. Not ethical, and patients are catching on, man. Patients, and with what's going on recent now, I mean, the profession is taking a hit on this, and it's going to continue as it applies to TMJ and now sleep apnea. And using an oral device for sleep apnea, I think, is valid. When I didn't focus only on TMD as a non-surgical procedure, which we really brought it down. I did my last little bit of office surgery about a year ago, and I'd cut out hospital surgery long before that, but now it's totally devoted to non-surgical TMD. But I did my share of oral devices for snoring and sleep apnea, which work fairly well, I have found. Then they pull the mandible forward, which opens up the airway and back. And as opposed to using more traditional treatment for sleep apnea, CPAP, the patients loved it. And we had better than fair results. I mean, I always quoted the patients, you're going to have your chance of having good results here probably in the 70 to 80%. And that's pretty much what I saw across the board. The problem with pulling the mandible forward, it creates distraction of the condyle out of the glenoid fossa, which frequently can create what? Inflammation within the joint and TMD symptoms. We saw it all the time. And I would warn the patient, if you do this, you may develop some TMD symptoms. but they went, I got to do something about my sleep apnea. I said, okay, well, give it a shot. And that worked out okay in most patients. But again, these expanders, which claim that they're going to lay down bone by pushing on the teeth and expand the mid-palatal raphe, or actually literally to lay down layers of bone that these teeth are going to move through. Not only it makes no sense, it's not scientific, it's nowhere. So you can see how we're really caught here. Again, so Botox falls in the same category. This is nonsense, and it is not approved by the FDA. And I bet at this point in time, it's not ever going to be approved by the FDA because it doesn't hold water. There are many other devices. The next one that comes up, and I started this without a list of things. I just wanted to actually produce it and get some information there to get you thinking in the right direction about this, thinking in the right direction, critical thinking, critical thought. I actually have an whole episode on critical thinking. What is critical thinking? But the types of treatments that have been used, the next one that comes to mind is capturing the disc, recapturing the disc. We had a doctor here in Nashville who for years focused and operated on this treatment for TMD, which has been promoted, I believe, out of several teaching, I wouldn't call them institutions. Again, I'll leave them unnamed, but they're always preceded by the word prestigious, the prestigious. And the prestigious teaching institution taught that you could recapture the disc by pulling the mandible forward, recapturing the disc, meniscus, and then you had to rebuild the bite, the occlusion, either by full orthodontic treatment or full reconstruction of the occlusion with crowns and bridges. And there was a doctor here in town who will go unnamed, but I can say that, who took many, many patients through this process, which took 2 to 4 years, and to the tune of, at that time, years ago, $50,000. And just within the past year, my associate and I here have been, and he is now deceased, and we've been we've been asked to treat at least a dozen of these people who have come in who are either finished with that treatment or in the middle of that treatment who have significant TMD symptoms. Some of them that I can help, some of them I feel we can't help. And all I can do is send them to a qualified orthodontist. First, you got to get your teeth to fit together. I can't do anything if you don't have any kind of occlusion and your jaw's sticking out a centimeter. And that was very common. And I'm sure it's still common. In fact, I know it's going on. These treatments, these high dollar treatments for recapturing the disc and doing phase 1 and phase 2. Phase 1 is a series of orthotic appliances to pull the mandible forward. Phase 2 is to reconstruct the bite. Ouch. There will probably be other episodes about this as this unfolds. There will be. It needs to be addressed in the profession. My next thought, it needs to be addressed in the dental schools. I have an episode on dental education and TMD. It is somewhat critical. I know that our dental institutions have time constraints. There is a lot to learn in dentistry. Then you're not going to learn everything in 4 years, both on the basic science and the clinical end of it. There's no doubt about it. And so there are time constraints and what they have to put their emphasis on. But I think that our dental institutions, our dental schools need to rethink significantly on where they spend their time and on what things they spend their time on. I think the basic sciences can be taught much more efficiently and apply much more to the area that the dentist will operate in. Of course, you need to know somewhat about the rest of the body, but you don't have to know what an orthopedic surgeon knows. In fact, an orthopedic surgeon doesn't know what he knows until long after he's out of medical school about, bones and joints and muscles. So there needs to be a big rethinking about TMD education, and it doesn't include treatments for TMD that would include psychiatric treatment, physical therapy, which again just addresses a particular muscle and relaxes it or does something to a muscle, when the originator of these symptoms is actually within the inflammation of the temporomandibular joint. This is what we found. This is what we have a documented, independent university study based on, which is a study of over 3,000 treated patients using a device, I'll leave it unnamed, a device that separates the posterior teeth, anterior teeth only occlusion, according to a very careful protocol, making sure that you do not get super eruption of the posterior teeth, because when you separate teeth, you can get super eruption over a longer period of time. But if you know what you're doing and you have a protocol that limits posterior separation to a certain short period of time, then going to long span, nighttime only posterior separation, it really works pretty well. And unloads the joint and allows the inflammation to diminish. When the inflammation diminishes, symptoms go away. Our profession is losing trust big time to the public. One of the things, and I'm going to finish this up pretty quick, but I just recalled, as I didn't know how I was going to go through this today, but yesterday it really stimulated me. I knew what I was going to talk about today, but yesterday I see patients on Monday only. I always do these episodes on Tuesday morning. And yesterday I had two separate patients who came into me that I had treated previously with the Urbanic device and protocol, and I didn't know why they were on the schedule. And these were two separate patients within a span of 4 hours. And each of them came into me and asked me for my opinion about another doctor, another dentist who said they needed to have something done. And they just wanted my opinion. They knew that I was not, both of them were in the realm of, one of them was in the realm of surgery and one was in the realm of general dentistry. But both of them knew I was not going to treat them because I don't do that anymore. I don't do oral surgery anymore, and I'm not a general dentist. But both of them had questions. They came to me for a second opinion because, as they said, they really trusted me. And why did they trust me? Because we solved their longstanding significant problems with TMD, headache, earache, whatever they were in these cases. Well, it's a compliment. And both of them, I don't exaggerate this, both of them in their own method, thanked me profusely for getting them out of pain, getting their symptoms down, and that changed their life. And they both voiced that, not identically, but they voiced that concept to me and thanked me greatly. And I thanked them for their statement, their trust. But, when I walked out of the rooms later on in the day, I thought, because it dawned on me and said, these patients, once you get them out of pain, they really trust you. And as I've said on many, they want you to be their general dentist. They want you to take out their kids' wisdom teeth. They want you to put in grandma's implant. All kind of things like that. we need to get back. We need to work on that. And what has been going on with TMD, the treatment of TMD, and the obvious unapplication of scientific principles for TMD. I mean, just common sense principles for TMD, let alone scientific principles, for decades has been ignored, totally been ignored. And why, I'm not going to go into that right now. I have my own opinions, and I'll let you form your opinion, but they have been ignored. So if you want to build trust rather than decrease trust and get away from stuff that's going on that creates, just a bad view of dentistry among the patients, and this is going viral here, this AGA thing. It isn't my opinion. I've been told it's going viral by my, dental establishment, dental colleagues here in Middle Tennessee. So if you want to build trust, you got to build trust by actually treating patients and getting the result. Do what you promise. Always do exactly what you promise and get the result. Enough said. More than enough said. I think I went over time. I'll figure out a way. I'll figure out a title for this episode. I really appreciate those of you stick with me the whole time. I appreciate it. I appreciate those of you who are members of our network of doctors who provide this service for TMD, non-surgical treatment throughout the United States. And we're growing rapidly, and we're going to grow faster than we are right now. I'm working diligently to make that happen. For today, I look forward to speaking with you at the next episode, which will be in a week. I am Tony Urbaniak, and this is TMD Demystified.